he'll probably be pointing toward his stomach. Okay, so I just need to listen to your bowel sounds before we get started and take a look at your abdomen. So I'll bring him up to do that. You always need to look at the stomach. It's hard to tell if you don't have the shirt pulled up, so always take a look. And then we'll listen to the bowel sounds. Okay? Have you been real nauseated? And he's probably been throwing up too. So his bowel sounds are absent or hypoactive. At this point, he's distended. Okay, so we're going to do an NG tube, which means we're going to put a tube in your nose. It'll go down your esophagus into your stomach, and then it should give you some relief from the nausea and vomiting and the pain even. You want to go ahead and have your suction set up before you get started. And always, it's so important for the CNAs and LPNs to be able to do this. So make sure that y'all come in and know how to set up suction. Make sure that your suction works, okay, and have that ready. Okay, gather all your supplies. And you know that we're going to need, I like to have a basin because they may get sick if their stomach is full. Sometimes they'll get sick. Some ice water will help. You need to have your tape ready. So you can tear a couple pieces of tape. Some people will say not to put tape on the bedside table. I don't mind if you do that because this is not a sterile procedure as long as your table's clean. So you'll want to wipe your table down first.
Miss Wall said that we can put tape even with the sterile as long as it's not on.
Yeah. So I mean, we're not doing anything sterile here, but you know, we don't want it to be dirty. So tear a piece of pants. And then just a regular piece of tape. Okay, you'll either need a Sharpie or this little piece of tape that I have here. And what we want to do, again, these are kind of hard in the beginning. So you might want to soak it in warm water so it's a little bit more flexible. Or again, you can just wrap it around your hands sometimes, but you know, just try to get it to bend a little bit so it's not so stiff. Okay, so we'll have this together. I do need to lower the side rails. Now, I'm going to set you up as straight as I can, but if for any reason you feel like you can't breathe or if you're having a difficult time during the procedure, you can just raise your left hand and I'll know that means that I need to stop and let you take a breath for a minute, okay? All right, so let's go ahead and measure your tube, and that is from the tip of the nose to the earlobe. And you can even take your Sharpie and just kind of put a mark there. That way you'll know when you get to the mark that you should be at the back of the throat. And then you'll go from the earlobe to the xiphoid process. Okay, so that is about 50, okay, 50 centimeters. Sorry about that. Okay. So, like I said, you can either put a very small piece of tape, and you don't want it to be real bulky because it's going to be at the patient's tip of the nose, so you don't want to have a bunch of tape there. So again, you can use your Sharpie if you want. Okay, so we've got all of this. We want to lubricate this very well and get this ready. You may have another nurse to help you over here, hold the water and help the patient get something to drink. And whenever I ask you to swallow, you're just going to help the tube go down by swallowing and trying to get that past your gag reflex, okay? So it looks like we are ready. I do want to sit him straight up, and I think this is as straight as the bed will go. It really helps if your patient's in half hours, okay? Sometimes I'll even put this behind their back. See how straight he's sitting? That helps. Okay, so we are ready to put the NG tube down. Here we go. Alright, so we're just gonna go to that first mark, which is at 15. So we know we're at the back of the throat here. We're about to go past the gag reflex, but you may just, that's kind of step one. You can look in the mouth just to make sure that it's not starting to curl up. You don't have to do that, but I like to tell you because you may see that on some of the videos. All right, here we go, and you're just going to take a sip of this and swallow. So someone's handing him that. We're going to go down the rest of the way. So here we go. And we're going to go all the way to 50. Okay, so we're at 50. All right, good. You did real good. We didn't even have to stop. So because I want to check for placement before I really secure this, that's why we kind of tear the pants here. And I just wrap one leg of the pants around this. But I don't secure it too much yet, okay? So just to hold it in place. If you don't secure it somewhat, it's going to shoot right back out at you, okay? Because there's a lot of pressure in that stomach. Okay, so first, we can visualize that we've got green fluids coming out. So we know that's one way to know we're in the right spot and not in the lungs. Second, we can do a pH check, and by doing that, you would just unclamp it, pull out some fluid, and then test your pH. Okay? They'll have some pH strips, or you'll send it down to the lab, whatever your facility says to do. Now, to do an air bolus, you would go ahead and pull your air back. Put your stethoscope, of course, it would be in your ears, and this would be right over your stomach. And just listen. And you do it kind of fast because you want that force, to make the sound. You don't want to just put it in real slow or you're not going to hear it. So just, 10 or 15 cc's of an air bolus, and you should be able to hear that bubble in the stomach. So then you would know you were there, and you can have another nurse verify that. Okay? So, at this point, you're going to connect to suction. This blue port is just a valve, air valve. So that's how you're going to hook it to suction. You turn it on and empty the stomach. Okay. You will stay on suction until your physician tells you to take it off of suction. But while you're here, you also want to secure your, secure your tube. Because you don't want it just dangling in the air. You want it to be secured. So that way if they pull, do you see how that's pulling the shirt and not on the tube? Of course you want to make sure that's attached well. Okay. There are other ways that you can secure this NG tube. You'll even see in your book where they put a piece of tape, and then they put a piece of tape around this, and you tape that to that, so it's not pulling directly on the skin. You can do that. But again, some people don't want to put tape on their face. A lot of people's face gets real oily, and it's hard to keep that on. Even these will kind of start drooping, so you may have to take them off every day or so and clean underneath it and make sure that you have a good adhesive there. So we're going to leave that clamped until the physician says otherwise. And this is what it looks like when it's clamped. Okay? That's it. And of course you would clean up afterward, offer oral care, or even nasal care if they need it. Yes?
How would you do the, we were talking about it in class.
Residual
Yeah.
bolus feedings. Both? Okay. All right, so I want to make sure that everybody understands you're not giving bolus feedings to people who are being decompressed, right? Y'all got that?
Yeah.
Because that would just not be right. Okay. So you're decompressing because they don't need anything on their stomach. Okay. So let's just say this is a different patient, and this patient came in because she had a stroke and she doesn't have a good gag reflex and she can't eat, but her family's trying to decide if they want a peg tube, and we just can't wait on nutrition. So they want us to give an NG tube, okay? They want us to feed her with an NG tube. So we've put it down, and now we're gonna feed this patient. Now, before you do that, you wanna check a residual. You don't want that to be full. So with an NG tube, all you have to do is put your 60 cc syringe on there and withdraw back. That's your residual. If it's less than 100, you put it back in and you can continue feedings. Okay?
So it's gonna stop. You're gonna have pressure when you pull out.
Yeah, whenever, like, it'll pull, you'll be able to see when it's not doing anymore. You'll get a bunch of bubbles and air, it'll stop, you know, or you'll just get back a whole bunch. You're like, uh-oh, here we go. And sometimes you'll fill this up and you'll clamp it, and then I'll put it in something, because we want to measure it, and I'll do more. So if we put more than one and a half of these, for sure, we're not going to continue if it's over 100, okay? But you also have to put everything back in. Now, someone asked, what if it's over? Is that what you're wondering? Okay. You are supposed to put what you take out. Usually what I do is, and it doesn't happen so often, I usually will not, if they're not throwing up, you know, if they're throwing up, then I won't put it back in, okay? Or if I pull out, let's just say 120, and it's still going, then I would probably clamp it, and I just know my residual's greater than 120, and I'll put that back in, and then I'll stop feedings and go from there. It really depends on your patient, okay? But the reason they say that is because, you have gastric juices and enzymes and stuff like this, so you don't want to take out everything that's in their stomach. You want them to digest that. Hopefully, if nurses are doing their residuals, you're not going to have a whole lot of residual, okay? Now, sometimes it's going to be over 100, and that's okay. Just put it back, move forward. But if, if it's much more than that, then you might just want to talk to your nurse and see what they want you to do. Okay, so that's our residual. Now let's just say it was less than 100, and we want to, I don't really need that, do I? We want to do our tube feeding. So I'm going to take this out, and I've got a cup of water here. So we checked our residual, it was 60, we put it back in, and I want to flush first, so I'm going to pour about at least half of this, and I might want to make it full, 60 cc's isn't that much, so I'll fill that up with water, let that go down, and then I'm going to start pouring this in here. Now you're going to let it get between half and 3/4 full, because you don't want it all the way full. If they cough, it'll burp out everywhere. Yeah. You don't want to let it get all the way empty, because then you would be putting a lot of air into their stomach. So again, half to 3/4 full. And then when you finish, again, we want to flush. Let that get down to almost empty, and then you'll clamp it like this. Okay? Miss Voss always says something like, if you put it up here at the top of the bed, then people will know that this is clamped after a tube feeding. no one ever told me that, but, you know, if I look at it and it's clamped, I know it's clamped. So, you know, what, you might see that in one of the videos though. Now, with this is a peg tube, okay? And the tube feedings and the residuals are the same. You do it exactly the same. The only thing that's different is here you have 3 lumens. So this is what your feeding's going in. You can do flushes through here, but over here, this is your balloon. This is put in, it's surgically implanted, but there's a balloon that keeps this from falling out. Like a Foley catheter, this has a balloon at the other end. So you don't want to withdraw any air from the balloon port or you're gonna lose your peg, okay? And it happens, it's not fun. So make sure that you don't touch the balloon ever. You're only using these ports, okay? And again, it's just like that. You just open up your port and, you know, pour it in, okay? Used to, we would push stuff in. Of course, then we learned about dumping syndrome and that sort of stuff. So usually we let it go in by gravity. You just pour it in, and again, the higher you hold your tube, the faster it goes in. If you lower it, it'll slow down, okay? All right, once you do that, let's just say your patient is now, we're back to the other patient now, okay? And this patient is eating a regular diet and he's having bowel movements, and the doctor, it's been clamped for 24 hours, so now the doctor says that we can go back and take the tube out, okay? So again, entrance routine, same thing. Always do an assessment. You want to make sure, have you had any nausea and vomiting? Did you eat your last meal? So do your assessment first. Always look at your abdomen and check your bowel sounds, and then we'll get ready to take the tube out. I like to have a washcloth ready and some tissue so they can blow their nose. Detach that. And instead of taking all the tape off of the tube, because it's so tender, it gets really, really tender, I'll just take the tape off the nose. Okay, and then I'll ask you to take a deep breath, and while they're doing that, you're just going to pull the tube out, and you're done. So you can hand them a tissue, do oral care. Always look at the tip of your tube though when you pull it out. So whether it's an IV or an NG or a Foley, any type of tube, I mean femoral catheter after a heart cath, any foreign device that you put in that you take out, you always have to look and document that the tip was intact. Because if it broke off in there, we need to know that. We don't need to leave a foreign body. It might not be something you go get, but that needs to, the physician needs to know, and we need to make sure that that issue's addressed. Again, it might not be your fault that it's in there, so don't feel like you've done something wrong, and don't try to hide it, just the tip is broken. Or you'll chart that the tip is intact. And just like with your enema bags, you can just pull that off and dispose of that, okay? So you'll just clean all of that up and do your exit routine, and then of course address your safety measures. Okay. And give the patient the call out, make sure the sun rolls up.